Dr. Alan, over to you, please.
Thank you. Good morning, everyone. Good afternoon. Welcome to this webinar. And I hope you can hear me loud and clear. This webinar is going to take us through orientation of priority areas for multi-sectoral interventions. They commonly call them PAMIs. And we are specifically focusing in the WHO Africa region. Just a small disclaimer to say that this webinar is in English, so we do not have interpretation. There are some sessions that are coming up that are going to deal with the French-speaking colleagues. Next. Before we start, just note that this is a virtual training. It adheres to a code of conduct to prevent harassment, including sexual harassment at WHO events. Next. For those who will have questions and chats, you will use the features of the Q&A. If you look down on your screen, you will see a Q&A feature, and that's where we are going to have you put your questions. And only the questions that are the Q&A will be answered during these sessions. However, we have provision for the live questions that will be taken at the end of the presentation. So we are going to go through all the presentations And then finally, we shall have Q&A session. Then for the chat, you use that chat feature for the questions regarding IT or logistics support. Next. For the live transcription, click on the show captions like indicated below the screen, and the caption would appear. And to close the caption, you just click the hide caption. We shall send you these recordings materials, and we expect feedback from you. This session is being recorded, and we take your attendance as consent to be recorded. If you do not want to be part of the recorded consent, then you may think otherwise. The materials for the sessions, including recordings, will be emailed for the participants that have registered. And we expect this to be done in about 2 days following the end of this webinar. As we continue to improve our training programs, we appreciate your feedback, and we shall share a survey at the end of these sessions. And we encourage you to help us and tailor any future sessions to better meet your needs. So please put in all the suggestions, all the criticism, and the feedback that you may want us to understand and help improve these sessions. Next. We have 4 panelists that are going to take us through the next 1.5 to 2 hours. We have Dr. Fred Kapaya, who is a technical officer for the Cholera Control Program. He works with the Regional Office for Africa, AFRO. He's an expert with over 18 years of progressive experience in public health programs. He brings a vast knowledge and extensive knowledge and experience in cholera preparedness, readiness, and response across all levels, both national, regional, and global levels. We have Dr. Anne Loarek, who is a medical doctor by training, who has helped support a number of countries. Recently, she has supported 3 countries to achieve PAMI identification for cholera control. She's currently working as a consultant for the GTFCC with the WHO headquarters to develop an online training for the PAMI identification. So you would definitely benefit from this training and product once she completes it. We have Dr. Randy George Wira, who is a public health physician and vaccinologist. Currently, he's with the WHO Malawi country office, where he's working as the health emergency surveillance and technical officer under the emergency preparedness and response team. He leads surveillance team at the country office, and he has contributed to the development of the PAMIs in Malawi. We do have the 4th panelist is Yamikan Lex Chilipo, who is a surveillance data scientist currently. She is the emergency surveillance GIS officer for Malawi, WHO country office, emergency preparedness and response program. He played a key role in the development and identification of the process of PAMIs in Malawi. So you realize we have a vast knowledge of experience from the panelists. My name is Alan, Mpeiri Alan. I'm currently working with the emergency preparedness program, specifically supporting IHR and country capacity preparedness for the East and Southern African countries. And I'm based in the Nairobi Emergency Hub. So I will be the moderator of this webinar. So as part of our agenda, we have opening remarks, which will be led by Dr. Mori Keita, who is our regional advisor based in Brazzaville. We shall have objectives of the webinar. Dr. Kapaya will take us through that. We shall have a presentation to understand what the PAMIs are. Dr. Randy will take us through that. We shall have a presentation on the GTFCC method for identification of PAMIs to develop a national control program. And this will be taken by Dr. Kapaya and Dr. Randy. Then we shall have a presentation on the tool for identification of the PAMIs to develop a national control program. And this will be led by Chilipo Yamikan and our colleague, Dr. Loarek. And then thereafter, we shall have a Q&A session. and then we shall end the webinar. So like I said, the Q&A session, we shall have, live questions where you raise your hands and we shall identify a few of you. We may not pick all of you. However, for most other important questions, please put them in the Q&A provision of the webinar such that the panelists are able to answer them in real time as we proceed. Just to let you know that this session on PAMIs is specifically focusing on the control. PAMIs for control. We shall have other sessions on PAMIs for elimination. So the French-speaking webinar will be next week for PAMIs of control. And then we shall have 2 other sessions, PAMIs for elimination, in the last week of this month, and then the first week of August. We shall share with you the dates. Specifically for English, PAMIs for elimination is on 25th of July, and then 1st August, we have a session on French for the French-speaking colleagues for the PAMIs for elimination. And then next week on 18th, we do have a session similar to this, but for the French-speaking colleagues. So we shall majorly here deal with English speaking, and you forgive us for that, pardon us for that, as we may not be able to take a number of questions. If we are able, we shall answer 1 or 2, but majorly we shall focus on the English questions raised in English. So before we proceed, I want to take this honor to welcome Dr. Maury Keita, who is our regional advisor within our emergency program, to give us a few opening remarks, and thereafter we begin our very interesting sessions on the PAMIs. Over to you, Dr. Maury Keita.
Thank you, Alan. Good morning, ladies and gentlemen. We come again with a webinar on the orientation of the identification of priority areas for multisectoral intervention, what we usually call PAMIs, or simply cholera hotspots. This webinar, the first in the series, intended to equip national level experts with the knowledge and skills to identify their PAMIs using scientifically proven methods. Since mid-2021, the world has witnessed an upsurge of the 7th cholera pandemic. There has been an unusually high number of cholera outbreaks associated with high mortality and spread to new geographic areas. This spike is caused by many factors, including armed conflict, climate change, water scarcity, and political instability. The Global Cholera Roadmap, launched by the Global Task Force on Cholera Control in 2017, aims to reduce cholera death by 90% and eliminate cholera in at least 20 countries by 2030. In 2018, the WHO African region adopted a framework for the implementation of the roadmap, emphasizing multisectoral collaboration, community engagement, and targeted interventions. This framework was endorsed by the ministers of health from all the 47 WHO Afro member states in Dakar in August 2018. A key strategic axis for the implementation of the global roadmap is the identification of PAMIs for multisectoral targeted interventions. If we can target the PAMIs where the cholera burden is highly concentrated, we can eliminate cholera in Africa. As technical officers, you are key to the implementation of the global roadmap, and you have been selected to attend this webinar for that purpose. I urge you to take this webinar seriously so that you will learn, you will be able to help your respective countries to identify the PAMIs. WHO is grateful to all our partners like UNICEF, MSF, IFRC, among many for this continued collaboration in the fight against cholera. Special thanks to all our member states for your commitment to this noble goal. As WHO, we will continue to engage and support our member states to ensure better preparedness against cholera. Together, we shall eliminate cholera in our region. Thank you very much.
Thank you very much, Dr. Mori, for those very interesting opening remarks. And we thank you for sparing your time to be with us, despite your busy schedule. So we shall move on straight to our first presentation. I will invite Dr. Kapaya, Fred, to take us through the objectives of this PAMI session. Thank you.
Okay.
The presentation is half. From my side, I see half of the presentation. I don't know whether it's the same on the other side, but just please reconfirm.
Are you okay? Is it okay now?
No. Yeah, now it's fine.
Okay, so thank you very much, Dr. Alan. So as said, I'm Freddy Kapaya. I'm going to take you through the objectives of this very important webinar. So our general objective is to orient and provide guidance to our member states on the identification of priority areas for multi-sectoral interventions, which we call PAMIs or hotspots for cholera control. And our specifics would like to explain what PAMIs are, the types, and the importance of identifying these PAMIs. We also want to describe the process of PAMI identification, also to introduce the GTFCC tool for PAMI identification, and also to enlighten member states about the support for PAMI identification, which will include the resources and materials, also the technical support, and how you can request for this support. Our expected outputs, we're simply saying at the end of our webinar today, our member states will be well oriented on the identification of PAMIs, the concept of PAMIs, the types, and the importance of identifying PAMIs will be explained. The process of PAMI identification was described, the GTFCC tool for PAMI identification introduced, and then our member states will actually be enlightened about the available support for PAMI identification for cholera control. So ladies and gentlemen, these are the objectives for our webinar today. I wish to thank you very much.
Thank you very, very much for keeping time, very clear and precise. So we shall straight away move to our next presenter to take us through what PAMIs are, such that they can set a scene for more presentations to come. Over to you, Dr. Randy.
Thank you, Dr. And so I'll take you through what PAMIs are. So greetings to colleagues from wherever you are. Thank you for joining this webinar, and I hope you're all excited the way we are to share with you and engage in the discussion and identification of PAMIs during this webinar. First, I'd like to acknowledge the leadership from all the levels of WHO and others present here, and all colleagues contributing to the cholera control, to the work against cholera control against the region. A very special mention to our WR, EPR leadership, and the WCO team here in Malawi for the gigantic efforts that they've put in controlling the worst cholera outbreak that we really had in Malawi. So just to give you a bit of background context, so Malawi has been recording cases since 1998, at least that's what we have on record. That's close to 30 years of reporting cholera cases. But during the recent outbreak, which started on 20th February 2022, we've recorded to date 59,360 something cases and 1,772 deaths. That's a whopping 3.0% case fatality rate, which is quite high. The efforts to control this outbreak have been phenomenal from all over, from the regional office, from neighboring countries, from internal partners, from the headquarters, as it was declared a level 3 outbreak. Then we've had a lot of investments which we've learned from, and hoping that these have built a lot of capacities that we will never see such an outbreak
Dr.
again.
Randy, sorry to interrupt, the slides are not
Sure.
moving.
Yes, I'll get to there.
Okay, all right, fine.
Yeah,
Thanks.
sure. Just to indicate that this outbreak also made it a priority for us to make sure that we identify priority areas for multisectoral interventions so that we should not see a scenario like this again. So with that said, let's see what PAMIs are. So today we will discuss what PAMIs are. So PAMIs are priority areas for multisectoral interventions. Formerly, these have been called hotspots. Most of you might have heard of the word called cholera hotspots, and that's what might be currently being used in most of the countries. So for identification of these PAMIs, there are two GTFCC methods that have been developed. So these are PAMIs for control or PAMIs for elimination. The major difference we'll see in the next slide being that one is done in a certain transmission type, and the other is done in also a different type of transmission. Further, we're going to discuss on when to use each of these methods, the key principles of the methods for these cholera control, the characteristics of the PAMI identification process, and how to access detailed guidance and technical assistance on PAMIs. Colleagues, I'd like to highlight here that this presentation or this session is not really a detailed technical training on PAMI identification, but rather an orientation. So let's keep that in mind and also have that mentality when we're formulating our clarification points. So as indicated earlier, there are two types of national cholera control plans and PAMIs, one for control and one for elimination. And as most of you might be aware, ending cholera and any other disease, infectious disease in particular, is a progressive pathway. So an integrated multisectoral national control plan is set it sets the country's objective, usually for 5 years period, outlining high impact interventions from all sectors to achieve cholera control or elimination. So endemic countries with moderate to high transmission will first aim to decrease the transmission within their setting, whilst countries with significant progress in reducing those transmission will target now going to elimination. So for the first type, the countries that do have some sort of moderate to high transmission, these would have national cholera control plans or priority areas for multisectoral interventions for control, whilst the others with low transmission to no transmission will have to develop national cholera control plans and PAMIs for elimination. Now, let's take a closer look to why these two methods are different or how they're similar. So as mentioned earlier, the major difference is the mode of transmission of cholera that within the country, which guides which method a country might choose. So for countries that have moderate to high transmission, which means equal to or more than 5% of the areas have reported cholera case over the period of 5 years, past 5 years. And in these areas, PAMI's identification primarily is based on the burden of cholera that has been experienced within that past 5 years. So here, the country might want to develop a national cholera control plan for cholera control. Whilst for PAMIs, for elimination, it is for those countries that have low to no transmission, which translates to less than 5% of the areas reporting cholera cases over a period of 5+ years. In these areas, the driver of PAMI identification is mainly vulnerability factors for cholera reemergence or emergence. And in these areas, cholera control plans are aimed for elimination. Now, let me just pause a minute and talk of vulnerabilities for cholera reemergence or emergence. This refers to factors that are based on country context associated with risk of either introduction of Vibrio cholera within the setup, or onset of cholera outbreak, or the spread of that outbreak within the areas of that particular country. Now, despite aiming for different cholera transmission settings, the two GTFCC methodologies follow a similar approach. So both of them are data-driven, where geographical units are scored using a numeric index to inform evidence-based or objective decision-making. This phase is then followed by a consensus building phase, which brings together multi-sectoral stakeholders to decide based on the consensus on the index threshold value. So then all geographic unit that with an index value that supersedes the threshold that the consensus has been made on automatically falls within the PAMIs. But that's not all. So we'll look into how we finalize the PAMIs, but in the next slides, but using additional factors. Now, the epidemiological indicators that are considered when one is developing a national control plan. So for the epidemiological indicators, a country will do an assessment of the National Cholera Control Plan operational geographic unit, which are defined as geographic unit corresponding to the lowest administrative level where resources are made available and allocated for decisions to be made for cholera control. The corresponding administrative levels in different countries are defined differently. So this could be administrative level 2 or level 3. For instance, in Malawi, when we did our PAMIs, we identified 421 administrative levels, level 3, that was a traditional authority level, which is a sub-district level. And for us, we used that level because that's where we could find substantial data, which was pretty much reliable, than going a level below that, because that's a village level that changes quite frequently. So the data that you now assess, you look retrospectively and assess data for a period of at least 5 to 15 years, depending on the availability of data within your setup. So the indicators that you assess for that period of time include the incidence, that's the new cholera cases each year in each specific unit that you're assessing, the number of cholera deaths, the persistence, which translates to the percentages of weeks with reported cases, and the test positivity indicator, depending on the representativeness of cholera testing. Because as you're aware, in some instances of the cholera outbreak, you really do not test consistently, but rather sample out a bit of the actual cases, the suspected cases for confirmation. So this might actually depends if the data is representative and then you add it into one of the indicators to be assessed. So for indicator scoring, this is just to give you an idea of how we score each indicator, the 4 indicators that I've just mentioned in the previous slide. So the principle here is that each indicator is scored for each geographical unit, NCP geographical operational unit. So for instance, if in Malawi we say traditional authority, so for each traditional authority, we had to collect data for all those 4 indicators. And then the score ranges from 0 to 3. So for instance, in the illustration table down the slide, you see that the indicator of mortality has a score of 0 if there is no death, score 1 point if the deaths are above 0 and below a median, which is set statistically, and that is something that will be discussed in the next session. And the score of 2 if it's more than 8, more or equal to the median and less to the 80th percentile, and 3 points if it's more than the 80th percentile. And all this will be clarified better in the next session. But just to give you an idea that how do we get from 0 to 3. So the threshold values for the scoring scale according to the indicators distribution in the country. So let's say one NCP unit might have a score of mortality of 1, and another area in the same country might have a score of 3, and another area in the same country might have a score of 2. So these thresholds for the score are not predetermined by, but they are country specific and also based on the data that you've had in the past 5 years, if you chose 5 years, or if you chose, let's say, more than 5 years. Malawi, we chose 5 years, 35 weeks, because that's the data that we had that was reliable. So for each country, it will be different. And then once each indicator has been scored, then you have a priority index for the priority index for the unit, which then you add all the 4 indicators. So if we do very simple mathematics, we add indicator for incidence, for mortality, for persistence, and for test. If all of them had the maximum score of 3, that means the maximum priority index value you can get is 12. 4 times 3 pretty much is 12. But the score can vary because not all not all scores will score 3 for all units. It will vary depending on the data that you have. So after scoring, you have your priority index value for a particular unit. And then the priority index value is what now is then deliberated and become a consensus is made by a team of multi-sectoral experts to say we agree that our priority index threshold will be at this level. Now let's look at that in the next slide. So the priority index value threshold setting is based on 2 main principles. Number 1, it is country specific. So it is as deliberated by multi-sectoral experts, and also, of course, a balance between feasibility and potential impact of the NCP. For instance, in the table below, let's just take a minute to go on the illustration table below. So the priority index value of this in this table that has been selected as for this, let's say, functional country is 10. So meaning that for if any unit within the country scores a priority index value of 10 after adding those the indicator scores, then that means they would have it would have registered 20 national control plan geographic operational units that meets that particular score. That means that covers 25% of the total population of that country, which has had 81% of cumulative cholera cases since that period of evaluation, whether it was 5 years or 15 years, and cumulatively has covered 47% of the deaths. Now, as a team of multi-sectoral experts, you would sit down and say, if we put all our high impact intervention in these 20 geographic areas, which have had 81% of cases and 47% of deaths, would it have an impact in our pathway to meet the targets of controlling cholera or eliminating cholera? But for interest of this presentation, in controlling cholera to the levels that we want, or do we want to come down to a priority index value, let's say 8, that will have cumulative impact in areas that have reported 94% of the cases and 84% of deaths. So as we said, it's country specific. It cannot be predetermined by anyone outside the country because you know your context. And then after setting up this threshold as the team, then you go to have additional PAMIs. So additional PAMIs, these are in some areas, the priority index might be underestimated due to surveillance gaps or OCV campaigns that might temporarily lower the priority index. So the countries are flexible, and therefore there's an option to be flexible, and it's really optional, really. So you can add additional PAMIs based on what you know as a context, but this should be based on documented assessment and justification. A number of PAMIs should remain limited compared to number of PAMIs based on the priority index. Otherwise, you might choose the whole country and defeat the purpose of prioritization. In factors that might be taken into consideration, to identify PAMIs are listed in the GTFCC methods and can be referred to. This is my last slide, just to show you that if the flow chart of choosing a PAMI, so priority index threshold that was set, if a unit goes above that, then it is a PAMI. If no, then you look at the optional, you look at additional variables. This could be variables including high transmission rate in neighboring countries, high population movement, cross-border issues, poor wash facilities, lack of OCV, cyclones, flood, population density, climate change, whatever that might come into your mind as a risk of introducing cholera vibrio into that society. If you feel that unit qualifies, then it goes to yes and becomes a list of additional PAMIs, and that's the final list of PAMIs. If no, then that's not a PAMI. So in summary, that's what PAMIs are, and that's how we get about to choose what a PAMI is. I will hand over to my colleague, Dr. Fred, to continue with the rest of the presentation. Thank you, Dr. Fred, over to you.
Dr. Fred, can you hear us?
So thank you very much. Can you hear me?
Yes, please go ahead.
Okay, so thank you very much, Dr. Randy, for that presentation. I would ask, maybe let me just go a slide before Randy. Just want to emphasize something. So, okay, so thank you very much, Randy. So what we are talking about when we talk about identification of PAMIs for control is that our emphasis is on epidemiological indicators. So it emphasizes on the cholera burden. And this is where you are going to see possibly the difference between PAMIs for control and PAMIs for elimination. For control, we are emphasizing on the cholera burden. So countries that have moderate to high transmission will do PAMIs for control, and countries that have low to no transmission will actually do PAMIs for elimination. And we'll be able to emphasize exactly what you look for. So in the PAMIs for control, when you look at this algorithm, you look at the NCP geographic units. These NCP geographic units are areas within the country that you are going to choose based on the context of the country, the areas where, for example, a district level or even below the district. So you identify all, for example, all the districts in the country, and then there you are going to score them using the 4 indicators that my colleague talked about. The first one being incidence, the second one persistence, then mortality, and then test positivity. And the maximum score for each indicator is a 3. Our colleagues that are going to take us through the 2 will be able to explain. So the maximum score for each indicator is a 3. And since there are 4 indicators, so N1 NCP unit can get up to a maximum of 12 indicators, or rather 12 priority index. So when you see this algorithm, if, for example, you have decided as a country to set a threshold, and those areas or districts have a priority index above, equal or above that threshold, say you have picked 10 or you have picked 8. So all those NCP units or districts that are above that threshold you have set above 8 will be picked as the initial list of the PAMIs. And then sometimes it happens that certain areas may be left out because their priority index has scored lower than the threshold. But you realize that those are still areas that have vulnerabilities and they can still spread cholera. Especially an example, in a particular district, if you just recently administered OCV, it means that their cholera incidence will be low. And therefore, even their persistence. So when you are scoring, you will discover that it may not score as high as other areas. So you may need to look at that. and then look at what are the vulnerabilities that exist. So if you look at that and you discover that there are vulnerabilities that exist for that district, despite the fact that it has scored lower than the priority index, the threshold that you set for the country, then you will still include it. It becomes, if it has vulnerabilities, then you say yes, it becomes an additional PAMI. So that is what is going to form the list of additional PAMIs. And now the final list will be the initial list of PAMIs plus the additional list of PAMIs. Now, what is important, ladies and gentlemen, is that all this work, especially when our colleagues go through this, they'll be able to tell you that this is automated. You just input the data, and then it will actually be able to calculate for you and show you all these values. The only work we have is to choose the priority index threshold for the country. We can go to the next, Randy. Okay, so now I take you through the process for conducting the PAMIs. So first and foremost, the first process which my colleague has explained is where now you have a technical team, epidemiologists, data people, surveillance officers. These are the ones that are going to input data into the tool and are able to actually come up with this list. Then you need a buy-in from the other stakeholders. So you are going to organize what is called a consultative meeting. Now, this process now, which is a new process or a new method, encourages multi-sectoral involvement, encourages consultations, encourages participation of everyone, so that at the end of the day, once we identify particular areas as PAMIs, everyone will know and they'll be able to plan for interventions in those areas. Unlike in the past, where when you talk to them and tell them that these are the areas we've identified, some of them would say, we never knew and we were not involved and we don't know what you're talking about. But now this gives us a chance to make sure that we do this. So we are saying that this is a participative kind of workshop that we're going to have, and then we're going to agree on the priority index, the threshold value. We'll identify the additional PAMIs, and then we'll develop consensus and a buy-in among all stakeholders on the final list of the PAMIs. Next, Randy. Next. So what are the steps? So we also want to explain to all of us that once we have agreed, we have first of all identified these PAMIs, the initial list of PAMIs through the epidemiological indicators. Then we have a workshop where we will now bring in other partners. So we then identify these PAMIs. What has been lacking in most cases is a report. So what GTFCC has done is they've actually provided a template for us to use to write the report. And this template, even online, you can find it, but we'll be able to share with you. So it gives you an outline of the things that you are supposed to actually include. Now, just filling in the Excel sheet that our colleagues are going to show, it's not a report or documentation in itself. So it's supposed to be supported by a proper report that we are going to even submit to a review, actually, committee that will look at your PAMIs. Next, Randy. So after you have done the PAMI identification and you've done the report, what is expected of each and every team is to now submit this report to the GTFCC PAMI Review Committee that is going to look through your report and ensure that you actually complied with the guidelines for PAMI identification. It is a requirement, especially all the countries that are doing OCV for control. You're also encouraged in one of the interventions you are going to do is OCV. Now, we know in the past requesting for OCV involves a lot of justification, writing to GTFCC, writing to ICG. But now, if you have done a proper PAMI identification, you may not need to go through all that process, because we use the PAMIs to request for OCV for prevention or for preventative vaccination. So this is very important. So all of us need to follow the procedure for PAMI. If you don't do that and you request for OCV, you may not actually get OCV because you have not followed the procedure for PAMI identification. The other thing that you need to know is that PAMI identification is very key, so that when you develop the National Cholera Plan, which is called the NCP, now this plan is supposed to be endorsed at the global level by GTFCC. Now, it can only be endorsed if you followed the method of PAMI identification. If you did not, then it cannot be endorsed, and then it cannot even be published on the website. And because of that, you need to know that the NCP, the plan itself, is a document that you can use for resource mobilization with partners. And now the GTFCC uses actually the platform to share with a lot of partners about the NCP in the different countries. So if it is published on the website, a lot of partners can come through to support the country because the plan is there, endorsed and agreed at the global stage. So it's very important. Now, the reason why we also need to submit to the GTFCC for review, we just want to make sure that everything that we are doing, we are in line with what is agreed. And we request rapidly, and usually the team takes about 30 days. And I must indicate here that in the African region, from WHO, Dr. Vincent and myself are part of the PAMI reviewers. So we'll review the document and then provide feedback. And once everything is done correctly, then your PAMIs will actually be validated and you can launch them. Next. So now, what about the resources? So there are lots of resources that have been produced by GTFCC, including what Anne is going to be talking about, the training materials that are being produced now. Now you can access all these with the link that is shown there. We are going to share with you. So all these materials are available online, and you can access all these materials to support or to help you with PAMI identification in your various countries. Next. Okay, so the GTFCC online resources, which you are going to receive, and when you use this link, there are 3 major documents that you are going to receive. The first one that you are going to get is the technical guidance on PAMI identification. So that is a resource which you can get. The second one is the Excel, the GTFCC Excel tool. Now, this is the tool that the colleagues will be sharing and showing us, which you use to do your PAMI identification. And then you have a user guide, which gives you a step-by-step guide on how to use or how to identify the PAMIs. Now, these 3 documents are supposed to be used together. So when you are using the GTFCC Excel tool, you should refer to the guide and you should refer to the technical document guidance, because it tells you each and every step that you are supposed to take. And should you have any questions, the answers are there in these documents. These documents are available in English, Arabic, French, and Portuguese. Next. And also, we have networks, especially within our region. But of course, the first one is the GTFCC Secretariat, and we are working with the GTFCC Secretariat and our HQ, WHO HQ. And this is why Anne is with us here. And Morgan will also be joining us. Then we also have the GTFCC Country Support Platform. So we are also working with the colleagues that are very key, because their role is to support countries, especially in the development of the national cholera plans. And then we have our regional offices for WHO. We are here to support. This is the network. We also have UNICEF, both regional and HQ, and we have Africa CDC. So everyone now is on board, working together to support member states in identifying priority areas for multi-sectoral interventions. Next. So the key messages. We are saying that GTFCC method to identify PAMIs for control, when you look at this, we are saying that control in countries that have high to moderate transmission is very critical. And identification of these PAMIs is very important for GTFCC endorsement of the National Cholera Plan. And also, it is very important to have PAMIs well done for the assessment of OCV preventive requests. So when you request, they will need actually to look at how you did the PAMIs. And we are saying that within this method, flexibility is given to countries to determine suitable indicators. I'll explain this one. So you have 4 indicators that we've talked about: the incidence, persistence, we've talked about mortality, and also test positivity. Depending on the data that you have in the country, sometimes you may discover that the data may not be very good and may not be very useful. I remember for Malawi ended up using 3 indicators. They removed the test positivity because it was very difficult to actually use that one. So again, flexibility is given to countries. But of course, we encourage, if you can have data on incidence, persistence, and mortality, and then you can actually use data to be able to identify the PAMIs. Then also countries can set thresholds. So these thresholds are based on the country-specific situation and also on consensus with the multi-sectoral partners that you are going to engage. Then you can also define the country-specific priority index threshold value, like I've said, and also consider additional factors which are optional. Next. So thank you very much. But Dr. Alan, quickly, let me just give about 3 slides just to explain something on PAMIs before we can move to the next. Rand, you can stop sharing this one. I want to share something very quickly. Dr. Alan, you can let me know if you are seeing or it's still looking.
We are seeing, but put
okay.
it in the PowerPoint slide. Okay, fine. Now it's okay now.
Okay, so I just want to explain something.
Please go ahead. Kapaya, you're muted. Dr.
Maybe I was muted by someone. Okay. Sorry. So we are saying that PAMIs are priority areas for multi-sectoral interventions. We want to understand what these PAMIs are. There are small areas where the cholera burden is highly concentrated, and outbreaks usually start from these areas. In the past, we used to call them hotspots. Now, why are they called priority areas for multi-sectoral intervention? Because it has been discovered that the fight against cholera cannot be done by one sector. It's supposed to be the involvement of everyone. So therefore, these are areas that are priority to all the sectors, and that's why they are called priority areas for multi-sectoral intervention. So you need the water sector, you need the environment, you need everyone to be involved. As my friend presented, so the global roadmap to end cholera calls for control and elimination. Now, it is very important to understand that some countries that have very high cholera burden cannot go to elimination. First of all, they should control. And when they control to low levels, then they can move to elimination, which usually looks at the vulnerability factors for reintroduction or reemergence of cholera. So I'll give examples. Countries that have had huge outbreaks, Malawi, Mozambique, Zambia, Zimbabwe, these countries should concentrate on control. Whereas countries that have very low, such as, for example, Namibia, South Africa, Botswana, these countries can go to elimination and only identify those vulnerability factors that can introduce cholera into their country. So that is why there is this distinction between control and elimination. And that's why the methods are slightly different. For control, we look at the AP indicators in particular. For elimination, we concentrate on identifying the vulnerability factors. So the purpose of PAMI identification, it's a decision-making step to inform interventions, and it guides geographic targeting of the intervention, and it is also a key first step in the development of the National Cholera Plan. So it is key, it is important for us to understand these elements. How long does it take to identify PAMIs? So identification of PAMIs usually requires 6 months, but you can shorten this process. So the reason why 6 months is indicated is that there should be very careful planning and also ensuring that everything is in place. So you should ensure that there is smooth articulation with the next steps, including how you are going to prepare a preventive oral cholera vaccine multi-year plan of action. So there is a link. So in the first month, you are going to concentrate on trying to understand what PAMIs are. So inception of PAMI identification. Once you understand, in the second to third month, you are going to be collecting data. And there is a tool that you are supposed to fill in, and our colleagues are going to show us the tool that will be filling in. Now, this is a very critical step because this is what will determine how the process is going to run and how effective it is going to be. So you need to look at all the NCP geographic units. If you have decided that your NCP geographic unit is the district, and in your country there are 20 districts, so you list all the 20 districts, and for each district, you are going to actually enter data on incidence, persistence, mortality, and test positivity. And you choose a period. I'll talk about that. And after you have done that, the fourth month, you do a stakeholder validation workshop where you bring in other stakeholders so that there is consensus building. The fifth month, it's the report. And then the sixth month, you can actually submit the report for review. But this can be shortened even to 2 months like we did in Malawi. It is very, very possible as long as you understand the process. So why should countries use this method? We are saying it is a strict prerequisite for countries to move forward with cholera control and cholera elimination. So GTFCC is a global organ that is guiding us on how we can eliminate cholera. And all of us, therefore, should follow this method. Why are there two methods? We have said that there are two distinct GTFCC methods because identification of PAMIs depends on the burden of cholera. If the cholera burden is very high, please concentrate on control. And if the burden of cholera is low, then you are going to concentrate on elimination so that you don't have any cholera whatsoever or any introduction of cholera in your country. So again, the question that may be there is why should countries with low to no cholera transmission still identify their PAMIs? The important thing is because of cross-border and the global trade, you don't want to reintroduce cholera in a country that has stayed quiet. So you want to eliminate anything that can bring in cholera. So this is the reason why you need to look at what factors can actually cause cholera to be introduced in our country, although we have not seen cholera in a long time. Good examples, now we are seeing cholera in the Comoros. So we should have done something before cholera was introduced in the Comoros. And that's what we are talking about. So no one is safe until everyone is safe. So to eliminate cholera sustainably, countries with low to new cholera transmission should maintain their efforts to prevent reemergence of cholera outbreaks by mitigating the cholera vulnerabilities. This is the last one. When we are selecting PAMIs, we use retrospective surveillance data. Usually the period of consideration is between 5 and 15 years. So you go retrospectively, this is 2024. So you can say, let's now identify PAMIs based on data from 2018 to 2023, that 5 years period. Then you go to all geographic units where cholera outbreaks were reported, and then each geographic unit should be scored to numerically vulnerability index. This is for elimination. We'll actually be able to talk about this later. And then vulnerability index based on vulnerability factors relevant to the country specific. So these are some of the things that I've already actually talked about. So ladies and gentlemen, thank you very much for your time.
Thank you very much, Dr. Kapaya and Dr. Randy. Very informative, clear, precise. You have brought up very key issues that we should put into consideration, and I'm sure the member states have really appreciated. And also, you have brought in the issue of cross-border importation of diseases. We have seen recently one in cholera. So very important, very key, and thank you very much for also sticking to time. So we shall move on to our next presentation, but just remind you that please put all your questions in the Q&A provision, such that our experts, continue to provide you more clarification and more answers. And then we shall, after this is our last presentation, we shall also have a session for Q&A to get more clarification. So without any further ado, I call on our two next experts to take us through the tool of what we have been discussing in the last 30 minutes. We have Chilipo and Dr. Ann, who are going to take us through this very important session about the tool that is used when we are doing these PAMIs for cholera control. Over to you, Dr. Ann and Chilipo.
Thank you very much, Dr. Aaron. So my name is Yamigan Chilipo, and once again, colleagues, welcome wherever you're joining us. I will take you through the GTFCC tool together with Dr. Annie, and the aim of this session is to provide member states with orientation on step-by-step of Excel-based tool in PAMI identification. Next. So the GTFCC recommends 3 steps to identify the PAMIs. The first step, which is to prepare a data set, is a preparatory phase to compile and consolidate all necessary data. Data will be prepared for the last 5 to 15 years at a standard administrative level, which the country intends to use for coordinating NCP implementation. So the national authorities may need to coordinate with regional authorities to retrieve historical data on epidemiological and context-specific vulnerability indicators for the study period. The next step is to upload the data and review the identification tool results, which is priority index calculation. And this step aims to score all NCP operational geographic units of a country according to numeric priority index. So this priority index represents multiple dimensions of cholera burden and is calculated from the sum of 4 scored indicators. And these indicators are incidence, mortality, persistence, and cholera test positivity. And the last step is to prepare a stakeholder validation meeting. And these steps, it aims to validate a final list of PAMIs. And it is at this step where a stakeholder will select a priority index threshold above which all NCP operation geographic units will be considered PAMIs. And in finalizing the list of PAMIs, contextual local knowledge that incorporates vulnerability to cholera transmission may be considered optionally in NCP operation geographic units with lack of reliability of the priority index. So the multi-stakeholder engagement in this process aims to maximize the buy-in and multi-sectoral engagement in subsequent steps of NCP development and implementation. Next slide. So the key points to be emphasized is the prioritization process. So even if the whole country is affected by cholera, PAMI identification will help decide where to start intervention and in line with the National Cholera Control Plan. So the identification of PAMIs enables areas of intervention to be prioritized in line with country and national control plan, and the PAMI process should be reviewed every 3 to 5 years to ensure that the prioritization areas correspond to reality and the nation control plan. So to say the PAMI process is not a static process. And the next key point is data collection process. So the epidemiological data is used to identify the PAMIs, and you don't need to have the best data. The data are collected during the outbreak, so part of the general surveillance system. They are generally not that perfect, but at least choose the best data, the best parameters, and population data per each geographic unit. So in the participation process, start to organize area meetings to agree on parameters, vulnerability factors, and threshold with the stakeholders to enable the buy-in of these PAMIs. So there are constraints and flexibility of the method in terms of the choice of median to score the indicators. Next slide. So the tools are available online on GTFCC website, and you can find the step-by-step user guide, which presents the overall methodology, and you also find a wealth of details and information on individual steps in the user guide. So on the same website, you also find the Excel tool that comes with the template to format the data, and also the 3 training data set with different representativeness of the laboratory indicators. You will see all these will be presented during the presentation of the executive tool. They are available with the links that you can just download and start manipulating using your own data. Next. So steps to identify PAMIs with GTFCC2. The first step is data preparation. So to prepare the epidemiological indicators, we'll first define the scope of the analysis in terms of time and space. Secondly, we will collect the data and upload to the tool to enable the tool to calculate epidemiological indicators automatically. And then we will also prepare the data about the vulnerability factors. And the last is to prepare the data model templates. Next. So to begin with the first step, to define the scope of the analysis. The scope of analysis includes the analysis period and the level of administrative units. So the analysis period should be chosen to consider potential changes in the cholera and risk situation in the country. As previous presenters has already alluded in, this is country specific, and we need to try to look at what has if the population has changed over the years, has the access to water and sanitation, even hygiene changed over the period. So the GTFCC recommends taking it into account at least 5 to 15 years in terms of calculating the PAMIs. And the choice of administrative units should be consistent with the level of administrative units in the NCP for cholera control intervention. In addition to this, the level of data collection and population size for each unit should be taken into account. So the GTFCC recommends considering administrative level number 2 or number 3 to enable mapping, so that you should have the shapefile at the country level at those levels. So for example, Malawi used the level 3, which was tier level, because the data was available in the surveillance forms. So both these parameters, the data must be checked to ensure that during the period and at this administrative level, the data are complete and accurate as possible. Next slide. So defining the scope of analysis. So we use an example of a certain country that used analysis period of 6 years. It considered that the COVID pandemic had had an impact on the surveillance system. So the last 5 years may be too short. So there was behavior changes and incomplete cholera surveillance, and also the cholera line standardization and improvement data surveillance for the last 5 to 6 years may have the impact on the data. So on the other hand, if the period chosen is too long, data quality and completeness may be problematic. So as a country level, there's a need to decide several epidemics to be taken into account. Next slide. And the other step is to compile annual surveillance data. So after defining the scope of analysis, you should also start to collect the data. So firstly, the data to collect will be population data. We should get the estimated population by administrative unit for each year of viewer study period. Usually these data are available from census at the National Office of Statistics or are compiled by US Census Bureau or by OCHA. So the population data are estimated from the year of census using national population growth rate or unit-specific growth. So potential sources and details about the data to collect are described in the user guide that you will find together with the tool. Secondly is to do with the compilation of epidemiological data. So on this one, we need to collect number of cholera cases suspected or confirmed to calculate the incidence, number of weeks with at least one reported cholera case that will help to calculate persistence, and number of cholera deaths that will help to calculate the mortality. So for the testing indicator, three different data will be compiled: the number of suspected cholera cases tested, the number of weeks with at least one suspected cholera case tested, and cholera case tested positive. So all these data should be collected per year and at each administrative level. Next slide. And again, there is issue of compilation of vulnerability factors, which is optional. There are two options. So information available for all units to be included in the input data set, and also to collect relevant information only for units undergoing discussion during the PAMI validation. So the data to collect concerning the vulnerability factors, this step is not compulsory and could not be done and could be not done only for specific units during stakeholder meeting. The vulnerability factors are used to discuss units where the epidemiologic indicators may be underestimated or biased. So for example, units with conflicts where the surveillance system may be challenged, or units where the population seeks care in the neighborhood units due to better health access or facility may be considered as additional PAMI. So this whole process involves the knowledge of the geographic units in order to be considered as additional PAMIs or vulnerability factors. So the GTFCC proposes a list of vulnerability factors in the guidance document and the user guide, but the country could choose country-specific vulnerability factors pertinent in their context, and the maximum of 12 vulnerability factors could be imputed in the tool. But you can choose less depending on the availability of the data. Next slide. So vulnerability factors would be entered as presence of yes or no, or empty cell. You can just leave it if that geographic unit doesn't have any of the vulnerability factor. So for some factors, it might be quite straightforward. For example, the presence of refugee population or cross-border PAMI, because at country specific, you'll be aware of the geographic unit. You know if there is presence of refugees or if the geographic unit is a cross-border unit. So it's a matter of scoring it a yes or no. For others, the data could be available as a percentage. In this case, either a threshold is already proposed in the definition of vulnerability factors. Next slide. So now you have all the available data, the administrative units with unique identifier. This is now the first tool, the data input table that will be used to compile all the data. So there is a unique identifier for the geographic unit with name, level 1 or level 2. There's a yearly population for the studied period, number of cases collected yearly, number of deaths collected for each year, number of people tested for test positivity collected for each year, number of people tested positive, there's number of weeks over the period, number of weeks with specified case, number of weeks with case confirmed, and the list of vulnerability factors, which are 12 in total. So each column on this tool represents a geographic unit. So you have a name, unique identifier, and now you begin to populate all the data sets. Next slide. So there are recommendations for importing the data in the GTFCC tools. So it strongly recommends to use the data input template. The list should contain all administrative units in the country, regardless of whether cholera cases were reported over the analysis period or not. And also there's need to prepare your data in the template that is available, and you have to have at least 5 years or above. Respect the order of the variables and naming convention. So in the user guide, there are rules for naming convention. And also you checks data consistent, data format, and missing data. There are also rules that are available in the user guide. Next slide. All right, thank you. So my colleague, Dr. Anne, will take it from here, calculating priority index. Thank you.
Hi, good morning, good afternoon. So we will look now at the tool itself, and first we will see how to upload the data, check the priority index, so which is the sum of the score, and access the different potential priority index threshold. So there are 4 steps to import your data into the identification tool. I will do an online presentation online. I hope that you see the screen. So this is a tool of the GTFCC for cholera control. Be careful, there is another tool for cholera elimination. On the first sheet, you will see some information and some key links. On the second sheet, you will have it will be where you will import your data. It's in yellow. And all the other green sheets, it's where the data are done automatically. The calculations, sorry, are done automatically. So you will have first a sheet which summarizes all the indicators and the score. It will be automatically calculated. You will have an overview table where you can cross-check your data. Then you will have a summary of your priority index distribution. Then tables about the vulnerability factors. And finally, on the last table, you will have all the information that are summarized and that is easily exportable as a CSV or as an Excel to do further analysis. So let's try with some data from the data training set. I took the data training with acceptable representativeness of the laboratory data. So the first step is when you open your tool, is to change the name of the tool to be sure that you use each time a new version where the formulas and the format has not been changed. So first open the tool, change the name, and then open the template where you have all your data and select the data, not the whole sheet, the whole data and copy them. You can paste them in the data input table using only the copy of the values. We should not copy all the data. It should be only the values. So this is the second step. The third step, you will see on the priority index calculation sheet. The first row is already, there are already calculation with the score with some threshold. You will have to select this first line and to extend this selection to the exact number of rows that you have in your dataset. For example, in the data training, we have 100 rows. So if I go a little too far, I will see that there are, for example, at 01, 02, there is no more data. So I have to decrease the selection to be at the exact number. And here I can see so all the indicators that have been calculated for each unit. So one row is 1 unit, and so for each unit, the indicators have been calculated, as well as the sum of the different score. So what we call the priority index. On the overview table, you will be able to check the description of your data, your number of units, your study period, your number of cases of death, and you will be able also to see the incidence, mortality, and persistence with the median and the 80th percentile that have been automatically calculated by the tool and that will be used as a threshold to score the different indicators. Then on the other table, sometimes you don't have the calculation that are done directly. For this, you need to go to data and to refresh all your data and tables. So when you do it, just click on yes for each window that pop up to be sure that all your tables will be updated. So here we see that the calculations are done. On the vulnerability factors tables also, there are some data, so it has been updated. And the export is also, have been also directly prepared by the tool with the different indicators, the priority index, and a summary of the vulnerability factors. Same on the export, 1 row corresponds to 1 unit. So this is for the preparation of the tool. Sorry, I go back to my presentation. So where we change the name, we copy the data, we extend the selection, and we updated all the tables. We already saw that the overview of check the overview tables, especially with the different the description of your data. And now we will have a little more. We will look a little more on the priority index summary. So if we use the same, sorry. If we use the same example of with the data training, the training data set, so we can see on the priority index calculation, the scores and the priority index. So if we take an example, for example, for the incidence, the median was at 21, the 80th percentile was at 62. So for the first unit, As the incidence is 74, it's above the 80th percentile, so it has a score of 3. And as also the mortality was above the 80th percentile, it has a score of 3. The persistence has a score of 2. And as the representativeness was acceptable, we take the positivity rate, and it was scored at 1. So we have a priority index. The sum of all these scores, it's at 9. As we are using 4 indicators with the best testing indicator, the maximum of the priority index will be 12. We have some example here for this unit where all the scores were at 3. If we have a unit without any case of cholera, the score will be at 0. So this priority index score each unit according to the epidemiological indicators and will allow us first to rank the administrative units according to the cholera burden. For example, on your export, you have already the units prepared rank by the priority index. And otherwise, we will use this priority index summary to see the distribution of the units per priority index. So for example, there is one geographic unit that has a priority index at 12, representing 1% of the geographic unit, a population of 372,328 people, so 1.7% of the population of the country. And in this unit, with a priority index of 12, we have 7,404 cases that were recorded and 47 deaths. So we can see per priority index how many geographic units are included, and this will help us to define a threshold of priority index to identify the PAMIs. So if we take, for example, this table, we saw that here in this example, it's a little different. With a priority index of 12, we have 2 administrative units. If we take a priority index threshold at 10, in fact, it will include all these geographic units. So the one with priority index of 12, so 2, priority index of 11, 11, and the priority index of 10, so 13 geographic units. So in total, we will have 26 geographic units. So in fact, it represents 26% of the geographic unit, 31% of the population, 86% of the cases, and 63% of the deaths that will be included if our threshold is 10. Usually, the best when we explore the data is to do different scenarios. So for example, here, one country took different scenarios to try to assess really the balance between the feasibility to choose this threshold, a specific threshold, and the impact on the health. So for example, here the country did 3 different scenarios with priority index at 4, at 5, or at 6, and evaluated the different consequences. What is very important is to map your data. Like this, it helps you to visualize really the repartition, the geographic repartition of the different units and priority index. Now that we have seen a little more that we have seen the tool, what will be important is during the stakeholder meeting to define with all the partners really this threshold. So you have explore, you have check your data, you have maybe done different scenario, but it will be with the other partners and local or regional authorities that you will define the final threshold. And then after, if needed, if you feel that your priority index may be biased for some units, you will discuss additional PAMIs using the vulnerability factors. So for these stakeholder meetings, just few tips. So really ensure to respect the two steps. First, the threshold to consider a unit as a PAMI, and then after, and only after, the additional PAMIs. Usually it's a 2 or 3 day workshop with all the different institutions that are involved in the National Cholera Plan, because really what is important is that the PAMIs are useful for all the interventions that are discussed with NCP. So WASH, community engagement, yes, all the different pillars. What we recommend also is to do a small presentation before to start the discussion to remind everyone the methodology and the process of the PAMIs, to have maps in a geographic system with which you can play in real time, adjusting with the different scenarios of priority index threshold. To have note takers and to use really the tool also, the export of the tool, to do a simplified export where the notes will be taken directly. Document really all your discussion, it's really important. And identify facilitators and people that will take the final decision, especially if there is really balanced distribution. Because really the threshold is really the balance between having a lot of units that will have a big public health impact, but where doing the intervention all at the same time will not be feasible. So it's a balance between a low threshold with a lot of units and a high threshold with a lower number of units. And this should be really discussed during your meetings. So this was again a small comparison. If we take a threshold at 10, for example, we have 26 units and 31% of the population where we will implement the NCP intervention, in comparison to a threshold at 8, where it's 48% of the unit and 50% of the population. So is it really feasible? And do you have all the means? Considering that really the PAMI, it's a prioritization. So if one unit is not selected as a PAMI this time, it could be done later when the PAMI will be reviewed. Concerning the additional PAMI, just to stress that it should be exceptional. It should be really based on objective reasons. So we spoke already about the lack of reliability of the priority index. For example, when there is a conflict and the surveillance is difficult, or when there is really the presence of context-specific vulnerability factors like refugees or a specific high-risk group. Usually, what we recommend is when we discuss additional PAMIs, is to have an idea of really the number of units or a maximum total percentage of the population that should be included in the final list, to really keep in mind this feasibility of the interventions that will really be after be the next step after the PAMI identification. And the same, justify and document all additional units because it will be key for the reviewer to understand your decision. So as a summary, the final list of PAMIs, so it's the one targeted by the intervention package of the National Cholera Plan. It consists of the initial list of PAMIs based on the priority index threshold and few additional PAMIs. And just to mention, because maybe you worked before with a hotspot where we were still considering prioritization among the hotspot for PAMIs, there is no more additional prioritization. There is no more high priority hotspot, medium or low. A PAMI is a PAMI, and it should be all of them should be seen at the same level for the intervention. We discussed already the report, just to remind you that there is a template that is available on the GTFCC website, and that it should really include all your discussions, the maps, and the tool also that has been used to show all the calculation. Then contact the GTFCC Secretariat to request an independent technical review. Thanks a lot.
Thank you very much. Thank you very much for the very good presentation and the tool. Yeah, I know we haven't had enough time to fully explore the tool, but I think for our colleagues in the member states, this tool, you will only understand it better if you practically use it. But this was a good oversight, and in case of anything that you need to clarify, this is the time. So our next section is basically a Q&A. So feel free to raise your hands, and then we shall give you access to the mic. And then also I noticed that there are some questions in the chat box, but most of them have been answered. So it's time for Q&A. Feel free to raise your hand, and then our colleague Amarachi will give you access to and unmute you so that we can be able to explain some of the issues that possibly you have not really understood. Okay, I see Lincoln, and this will be followed by Kola Jinadu. Dr. Lincoln, Sharimari. We cannot hear you. Dr. Sharimari, can you hear me? I think there's a problem. Dr. Kola, as we wait for, I hope it's not a general. Okay.
Thank you,
Dr.
Dr.
Kola.
Can you hear me?
Yes, we shall come back to Dr. Lincoln after you. Dr. Kola, please go ahead.
Thanks, Dr. Alan. Thanks to all the presenters for the great presentation. So it's just a comment from my side that how comfortable or how confident are we to say that maybe the countries independently use these tools? Do we have anything in plan in terms of having a kind of regional training, like a kind of hands-on training for countries to be able to use this tool? Because I think that this is a good step in the right direction to start with, but I don't know whether we've had such trainings in the past, or if not, do we have any plan to have this done, in which we are going to invite members from, invite colleagues from member states to be part of this training? Thank you, Honorable.
Okay, we shall take note of that. The first question will go to Kapaya. Kapaya, you will answer it later. Let's take all the questions. Dr. Lincoln, try you again. Dr. Lincoln says he's unmuted. I think there must be a problem with these settings. Dr. Charimali, feel free to type your question in the chat and I'll read it out. I think there's a problem with possibly your settings. Okay, Dr. Victor?
Thank you very much, Dr. Alan, for moderating, and thank you very much, team, for taking us through this training. This is very, very important reading, and on my side, I've learned a lot. With the last presenter on the tool, I must sincerely say that I may not be very confident to apply this tool. Maybe we might need another session. Let me be very honest. But there's something I've picked up. This tool, how can, I'm looking at the real context at the country level. How can the uncertainty, the sensitivity analysis be integrated into the calculation, if it is not there, of the priority index to account for variability in data quality, parameter estimates, and model assumptions? And if it is already catered for, how can this analysis influence robustness of the priority setting process? I'm just trying to come from the negative angle to see that if to ensure that we have quality data that comes in, how can that one be done, or if it's not done? Thank you very much.
Okay, thank you. So I think let's take the two questions, Dr. Kapaya one, and then our colleagues who presented the tool, Dr. Ann and Chilipo will answer the second question.
So
Dr.
thank you
Kapaya?
very much. Thank you very much. I hope you can hear me. So the question from Dr. Kola regarding any possible plan for regional training. First and foremost, just to indicate that this is a new tool. I think the materials were just published, I think, early this year. And like Annie indicated, we are just finalizing the training materials, and these are the materials that we've used. That's number one. Number two, yes, there are plans going forward to consider having a regional, and I think the discussions are ongoing to see how we can do this with HQ as well as with Afro and also other partners, and that's why we are calling on the other partners. But one thing that I just want to indicate here is that the tool is not really complicated to use, I must indicate. And countries that have used, Cameroon is a good example, Malawi is a good example. So in an event, I know this is just an orientation, but when we are able to sit even just online and take on a particular country, for example, and the team of experts, and take them step by step, within 1 hour or so, they will be able to understand the tool and how to input the data. So it's not complicated and very interesting, to say the truth. So I agree, Dr. Kola. We are looking into that, but I think countries should not wait until there is a regional training. We are encouraging countries to reach out to us, and we can provide direct support to the countries. So we can still sit down with each and every country. Now that you understand what this process is and what is involved, now we can sit down with each and every country and provide the necessary support. And this is what we've done to few of the countries that have already conducted the PAMIs. I'll leave the other question to Anne and Chilipo, but just to indicate that this method from Victor, it's very comprehensive and has taken into account a lot. Some of the Excel sheets that Anne was opening has actually addressed some of the question that you have asked, but let me ask Anne to comment. Thank you.
Thank you, Kapaya. And Dr. Charamai has posted his question in the chat. So please read it. And after Anne and Chilipa have finished, then I will request you to answer it live. Anne, over to you.
Yes, thanks a lot. So concerning the training, yes, for the moment, we will prepare
Is it my side or have we lost Anne?
We have lost her. We lost her.
Okay. Maybe we shall come back to her. Chilipo, you want to step in or we give Kapaya a chance as we wait for Dr. Anne?
You can go to Kapaya. I think I missed it, unless if he can type it in the chat so I can respond.
Okay, Dr. Kapaya, you can come on and then we.
Yeah, so thank you very much, Dr. Alan. I've seen the question from Dr. Charimari, but let me also comment on the question from Victor, a very important question. The need to look at sensitivity testing and the data. So that has actually already been taken into consideration, especially when the tool was being developed. That was taken into account. And that's why when Anne was presenting, she presented to us an example of data which is called acceptable, okay? There is also data that may not be acceptable. And that's where those percentages, when you look in the tool when she was showing, they were showing acceptable representativeness of the data, and you can have an acceptable representativeness of the data. So that is actually on data quality. But I think I like your question, how can we also take into account certain other factors? But the other thing that you asked was the issue of these PAMIs and the issue of multisectorality. Now, it's up to the country because you need to identify all the partners that are very key to cholera control, cholera elimination, and they are part of the validation workshop. And Dr. Anne said the first thing you do in the validation workshop, you make a presentation of the process of the PAMIs that you did so that they know. Then from there, you are going to have a discussion. It's about 2 to 3 days meeting so that everyone understands the process, everyone appreciates the identification of these PAMIs, and then everyone now becomes part. They agree that, yes, these are the PAMIs, and because we have agreed, all of us, so we are going to work together to ensure that we target interventions in these areas. And I must indicate, based on each and every PAMI, you may discover that there may be different interventions, okay? Because you may have, when you look, when you add the additional vulnerability factors, you may discover that one area may have bigger problems with WASH than the other. So even when you are planning your interventions, you are now going to look into all those areas, and then you can also share responsibilities. So here it comes to the accountability framework with all the partners and say, colleagues in WASH, these areas have this kind of challenges. What can you do and stuff like that? The question for Dr. Charimari regarding Zimbabwe that already has a national cholera elimination plan, it's similar to Zambia. They develop a national cholera elimination plan, Ethiopia, Kenya, Sierra Leone. So what it is really is not to redo the whole plan. But like what they are doing in Zambia, they are just updating. And they are just updating, and in updating, they are changing the name. For example, for Zimbabwe, we were just discussing that we need to actually redo the PAMIs because of the recent cholera outbreak. A lot of things have changed. So you may need to update the PAMIs that you have in your NCP. And when you do that update, you can actually now just update to say now it's a control plan. There is no need to redo the whole plan. The process is almost the same, although CSP has now released the guidance, but it is just to do an update on the NCP. Thank you.
Thank you very much. And nice to have you back. I think Dr. Kapaya answered part of the question, if not fully. Do you want to add anything before we move on?
Just maybe to stress that the online, you will get support either by training or by reaching the regional office or HQ office. And secondly, the data user guide. The user guide that is available online has a lot of information, both for each indicator, sorry, and it will describe all the checks that you could perform to ensure the quality of the data, all the different options if you face a problem. So don't hesitate to have a look on this user guide. It will really be your key documents when you are performing your PAMI identification.
Okay, thank you very much. Most of the questions in the chat have been answered. Our colleague, we had a colleague who had put up the hand, I think it was Emmanuel, but I see he has put it down. Feel free to raise your hands. We still have about another 6 minutes to conclude. But just read the questions. Emmanuel, I'm coming to you shortly. Just read the questions in the... Abraham was asking if the app, the GFTCC app, is updated to include this tool. And the answer is not yet, but they have provided for you the links of the resources. Gabriel Ayeni was asking, how do we link PAMI with CATI implementation? Also, more sessions will be needed to understand the PAMI tools better. I totally agree with you. And the answer is that CATI is an interventional approach when cholera outbreak is going on. PAMI is identification of areas where we need to focus interventions. When PAMIs are identified and an outbreak occurs in one of them, then you use a CATI tool. So very good insights on that. Gift was asking, in a country where 95% of the population is vulnerable to cholera, no safe water, no toilets, poor sanitation, no poor drainage, will PAMI be applied? And this answer, I think, is there. Clear. Identification of PAMI enabled us to know the most risk areas of cholera. Even if the population is vulnerable, we can apply the approach to identify and prioritize areas for interventions as much as the resources are scarce. So PAMIs are very important, and they will help you to have targeted interventions. Emmanuel, please, your question.
Thank you very much, moderator. Thank you, Dr. Kapaya, for your very beautiful presentation. I just want to ask a question. The Malawi PAMI approach, which we were packed together, had some challenges. Have those challenges been put into the final document that's going to be released? And if possible, can you share with us how what was done in Malawi has helped the country as a whole as of now? Thank you. Over to you.
Kapaya, over to you.
Okay, so before I answer that, can I ask Dr. Vincent wanted to add, and then I'll tackle that and ask Randy to also come in on Malawi. Dr. Vincent.
I would like to come back to the question of Victor on how we can integrate, how we can act on uncertainty and sensitivity analysis. I want to add to the point raised by Kapaya that after this data analysis step, it was presented that we have a forum of experts of the country to add to this quantitative analysis all the other aspects of qualitative analysis, including this uncertainty, additional factor that may be taken into account. And that's why, in addition to the area that are prioritized using the tool, the presenter emphasized on the possibility to have optional hotspot or PAMI that can be identified by this forum based on other aspects that is not taken into, that cannot be taken into account by the tool. So this forum of experts, they will analyze the situation. They will see the other factors that are not in the tool, other field context that is plaguing cholera in some area. And based on that, they can say, even if the tool didn't identify this area as PAMI, we need to add it based on these, and these factors. So the tool will not solve all the issue, and that's why we add this level of analysis after the result of the tool for prioritization and giving possibility to country to add optional PAMI based on other context. Over to you.
Okay, so thank you very much, Dr. Vincent. Very, very important. I think that when we did the PAMIs for Malawi, the major challenge that came in and which we immediately sorted out was, and this is what probably Anne was trying to say, it's when you are entering data. So I'll give an example. So when you do the period 6 years, so when you want to calculate the number of weeks, it's the number of weeks for 6 years. So you know in 1 year you are 52 weeks. So you need to count all those weeks for the 6 years. And then the mistake, and colleagues are here. So for example, you indicate that you have had a cholera case for incidence. But when it comes to the number of weeks when the cholera cases occurred, there is no week. That one has been missed. So then the question is, when did this cholera case occur? So once in the two, that one does not, it's not, if you have a case, then it occurred in a particular week. So if you discover that actually that period or that year, there was no week when there was cholera, but you have indicated that there was cholera, then the two will actually flag it off as a mistake, and that we actually immediately corrected. What has happened afterwards? What has happened very interesting and very good for Malawi. Malawi has actually moved very well. They've just done an expression of interest to GTFCC by government after doing the PAMIs, now to proceed to do the development of the National Cholera Control Plan arising from the PAMIs. So it's one of the big steps that Malawi has taken, but I'll allow my colleague Randy to comment on that one. But before Randy comments, Dr. Alan, there's a question where someone has asked, a colleague has asked about Kenya also having a national elimination plan. Just to emphasize, in the beginning, from 2017, after the launch of the global roadmap, the main aim was on elimination. So all the countries that first developed the plans, they developed elimination plans. But you'll agree with me now, the cholera that we are seeing now, there is no country which is safe. So you remember at that point, there was targeting of the countries where we should concentrate, but now all the countries are actually at risk. So GTFCC revised their guidelines and indicated that now we should have control and elimination. So the reason why the plan for Kenya, for Zambia, for Zimbabwe is still elimination, because these were the first countries to develop the plans. So for now, all they can do is to update the plans. And I agree with you, we use the plan as a tool for resource mobilization because resources are a big issue. Randy, maybe you can comment regarding what is going on in Malawi.
Sure. So for Malawi, indeed, we completed the process, but we had some challenges finalizing the report. As mentioned in the presentation, finalization of the report is quite a crucial step in submitting the same to GTFCC. So what had happened is that we finalized the process, completed the two, defined the PAMIs, had them validated by a multi-sectoral team of experts, including the Presidential Task Force representation, the Presidential Task Force for COVID-19 and cholera control, which was for us a very big show of political commitment from that end. So once that was done, the document was thought to be completed, and it was now being used for resource mobilization, decision-making, guiding interventions. But the final report to GTFCC was still slugging to be completed. So we've really had challenges pushing for that. And I think it's one of the hassles that most countries pursuing this might meet, and something that may need to be planned ahead to make all stakeholders understand that just having the result is not the final piece of the puzzle, but also making sure that you document the process, and then you're able to submit that to GTFCC for endorsement, and then it can be used for all these other requirements, OCV applications and stuff like that. But I'm glad to say that we've recently been able to finalize that, and it was signed, and I think I should confirm though, but that should be submitted to GTFCC very recently. So that was one of the challenges that we met. And of course, the other challenge is also bringing all sectors together. So it's sometimes difficult when other sectors really look at cholera as a health problem. So really difficult to convince them to bring them on the table. But either way, it needs a little bit more lobbying. And we're also grateful that the Presidential Task Force was redirected to also coordinate cholera intervention. So they were able to bring other ministries without difficulties, which was different at the beginning when Minister of Health was leading the whole process. To call on Minister of Agriculture, they would not really prioritize such interventions. So those are some of the things, but a publication will be made on lessons learned and best practices, which will be shared widely with all countries that are willing to do this. Thank you, and back to you, Dr. Allen.
Thank you very much, panelists. Very interesting and very insightful responses. I think we are running out of time and we have to bring this to an end. A lot of issues have been discussed, and yes, this is the beginning of many series that we are going to have, like I mentioned. And the more you engage with the experts, but also the more you engage to apply with the tool, then the more understanding we shall have. So I will take this opportunity to call Dr. Vincent to make the closing remarks. Dr. Vincent is one of our senior experts in the round of cholera, and currently is also the team lead of the emergency preparedness team in the Dakar hub. So over to you, Dr. Vincent.
Okay, many thanks, Alan, and all the colleagues for participating to this webinar. The objective was presented at the beginning by Dr. Mori. We want really our country to take steps on preparedness to cholera. And to be ready for cholera, we need to identify the PAMIs in our countries and implement what we can do in main pillar to make this area ready for early detection and response to cholera. We know that this webinar will not give all the answer and all the capabilities to countries. And I can assure you, as raised by Kapaya, that we are working to have proper training on the tool. And also we are ready to support technically all countries to implement and conduct the PAMI when they require it. This is a first webinar in English. We have the second one in 2 weeks' time, and we will emphasize on the tool for elimination. After the second webinar, you will be empowered with all the tools that are available, and depending on the profile of your country, you may know which tool you will use to conduct the PAMI. So I want to thank you for participating. I see that there were a lot of interest and many questions that were raised. And we will take all these questions and develop proper response and share with the participants also, in addition to the presentation that were done during this webinar. So many thanks. Have a good day, and let's see in 2 weeks' time for the second webinar on elimination. Over to you.
Thank you very much. Thank you, Vincent. The closing remarks. I want to thank everyone. Thanks, Fred. Thanks, Vincent, once again. Thanks, Nicole. Nicole has been in the background answering most of the questions. Thanks, Anne, Randy, Chilipo, Amarachi, who has been on top of this processes of ensuring that this webinar is successful, and Eric. Thank you very much. And with these few words, we bring this session to an end, and have a good week ahead. Bye-bye.
Goodbye.